Okay, this video is called How the Kidney Explains Brain Damage, and basically we're able to measure kidney damage very precisely, but it explains similar mechanisms of loss of brain cells, and by understanding the kidney you can better understand how to protect your own brain. So here's a picture of the kidney, and the blood comes into the kidney through the artery, the renal artery, and then it goes through these little things called nephrons that are blood filters. And then the purified blood enters the vein and is taken away from the kidney. The waste products are excreted into the kidney collecting system, go down through the ureter to the urinary bladder. So here's the artery. It comes into what's called Bowman's capsule under arterial pressure. And then some fluid from the blood is filtered into the kidney tubule. This thing right here is called the glomerulus. This whole thing is called a nephron. And then the urine travels through these little tubules back and forth until it finally goes into the collecting system in the ureter as urine. But during this process, as it's traveling through here, a lot of stuff is reabsorbed. There's stuff that the body wants to keep. The body's kind of designed to keep sodium and to excrete potassium, because our ancestors used to have lots of potassium in their diet, not much sodium. Nowadays we've flipped that. But anyways, you need to know that this thing is called a nephron. You have to know that. That's important, because the kidney filtration system is based on those nephrons. Here's sort of the big gross anatomy version of it. And you can see, the urine is filtered from the kidney into the ureter, travels down to the urinary bladder, goes into the bladder. Okay, you can have kidney failure from mechanical obstructive purposes. If you get a kidney stone right here, it'll obstruct the urine outflow, and this will cause back pressure. This will dilate. That would be called hydronephrosis. You can obstruct the ureter with lymph nodes from a cancer. Stone can be lodged distally in the ureter. You can have a bladder cancer, prostate cancer obstructing it. Okay, but the most common thing is a disease of the kidney, like atherosclerosis, diabetes, hypertension. Okay, now here's something that's going to be important to have a general understanding of. Now we're going to talk about glomerular filtration rate, which is those little things called glomeruli, the rate at which they can filter the blood. Okay, if you've got, let's say we'll call normal kidney function a GFR. GFR is glomerular filtration rate. So normal, we'll call it 100 and higher. All right, stage 1 kidney failure is when it's still above 90, so it's pretty good. Essentially, you're still functioning pretty close to normal. Stage 2 kidney failure is when you've got 60 to 90% of normal GFR, glomerular filtration rate. Okay, yeah, lots of people are hovering around 60, tons of them. Okay, then stage 3 is when you're 30 to 60%. And this is relevant because a lot of people donate a kidney for kidney transplant. So when somebody donates a kidney for kidney transplant, they've just lost 50% of their kidney function, but they still do reasonably well. Okay, they'll still have a GFR in this ballpark. And then when they get down to about 30, a GFR down to 30, then they're in serious kidney failure. And you have to watch them very carefully. They're at high risk to progress to having only 10% of optimal kidney function, in which case they go on dialysis. And dialysis really stinks. You don't want to be on dialysis. It's 3 days a week for 5 hours at a time. They're connected to an artificial kidney. So everybody wants to do everything possible to avoid going on dialysis. Once they hit a GFR of about 30, we'll no longer give them iodinated contrast in the IV for CAT scan. We'll no longer give them gadolinium in an IV for MRI scan. So it's a big deal to hit 30. Okay, and the other point is when they've got a GFR of 100 and over, they've got 1 million neurons. All right, once they hit a GFR of 90, it's about 900,000 neurons. 60, about, well, I don't mean neurons, I mean nephrons, the kidney filtration little filters. When you're at 60, you got 600 nephrons. When you're at 30, you got 300 nephrons. When you're down at 10, you got 100,000 nephrons. So the point is, you want to save those nephrons, like Saving Private Ryan. It is a big deal. You have to save and protect those nephrons, because you drop down to 10% and you're going to end up on dialysis, and that's a pretty miserable experience. Okay, again, here's the anatomy like on a CAT scan after iodinated contrast has been given. This is a normal kidney. This is the cortex, like the bark of a tree on the outer surface, lightened up with contrast. Here's the renal medulla, where the nephron tubules dip into there and they produce the urine. Then it goes into the urine collecting system. This is a stone obstructing it, causing hydronephrosis. There's the sort of the parent of the stone, and there's the part that broke off. But anyways, this is what it looks like on a coronal CAT scan with the patient facing you. Okay, here's a more detailed picture again of the staging system, and the key point was renal transplant. You've given up 50%, and you still have pretty good kidney function. So you can handle the loss of 50% of your kidney function pretty well, but you start going beyond that and you run into real problems, okay? And I see this all day long. It's routine for people over 50, over 60 in the United States, because they eat all these high-fat, high-meat diets, to have mild kidney failure in this stage here, of stage 3. But if you take good care of yourself, you can keep normal kidney function all the way until, you're 90, 100 years of age. Okay, so this is the key thing to know. These are the nephrons, and these are what we're trying to protect. And so what messes them up? Well, if you get atherosclerosis and you plug up this artery right here feeding into the kidney, that's going to damage your kidney function. If you damage this artery because of hypertension or diabetes, that's going to sclerose off your Bowman's capsule. You're going to lose those nephrons, okay? And there's some other rare diseases, but most of the time it's related to diabetes, hypertension, and atherosclerosis. Here's just an article that's talking about, what's the normal amount of nephrons in a kidney. And again, like I said, it's going to be about 1 million is like what you start out with. And then I gave you the correlates for how that goes with the GFR. Basically, for every 10 units of GFR, you lose about 100,000 neurons. So that makes it easy to calculate. And you can measure very precisely how the kidney is doing. You just check 2 tests. You check GFR, glomerular filtration rate. So here's the GFR right here. And that tells you exactly what's going on in the kidney. You can also check BUN, blood urea nitrogen. How well is the kidney able to get the nitrogen out of the blood? Because nitrogen is toxic in the blood, and that's the main job of the kidney. About 75% of its energy goes to removing nitrogen from the blood. It also excretes other toxins. It has to balance electrolytes, and it has to balance water volume with regard to controlling blood pressure. Okay, here shows how the kidney atrophies over time when a patient's going into kidney failure. So here's a normal-sized kidney, stage 1, and as the worse the kidney failure gets, the more the kidney shrinks in size. So here's a severely atrophic kidney. A normal function kidney is typically about 11 centimeters in length, whereas an atrophic failed kidney is about typically 7 or 8 centimeters in length. Now here's an atrophied brain. So an atrophied brain means that a normal brain, the brain's up tight against the bone. This white stuff here is the bone. This is a CAT scan, so it's based on density. So you call this a tight brain. So a young, healthy brain is relatively tight up against the inner table of the skull. Here's a lot of atrophy up anteriorly. This dark stuff is cerebral spinal fluid, just like it is in the ventricles. So when you get an excessive amount of fluid, that means this brain is quite atrophic. So whenever I see a demented brain, most of the time this is what I see. I see an atrophic brain where there's a big CSF space, cerebral spinal fluid space, between the skull, the inner table of the skull, and the brain itself. So severe diffuse atrophy is what I most commonly see in a demented patient. There's other things, of course. I can see a post-stroke dementia. I can see other causes of dementia, but the most common thing is diffuse cerebral atrophy. All right, so now we're looking at grades of cortical atrophy. So here's grade 0, a relatively normal looking brain. Grade 1, these are MRI scans, so they look a little different, but the concept is the same. You're seeing more prominent cell size, a little more prominent ventricular size. Here we go to grade 2. The vents are getting a little bit bigger in their side-to-side diameter. The cell side, the CSF-filled space here, it's a little bit bigger, and here it's even worse. Bigger vents, ventricles, and more CSF space. Okay, so that is progressive cerebral atrophy, and it correlates with how demented the patient is. Alcoholism will do that, atherosclerosis, hypertension, diabetes. So here's the heart down here, pumps blood into the aorta, goes up into the common carotid artery. Here's the internal carotid artery at the bifurcation, external carotid artery. This goes up to the brain, middle cerebral artery, anterior cerebral artery. So the point of the matter is, a high-fat diet will typically cause atherosclerosis in the internal carotid artery origin, also in the coronaries of the heart. That's heart disease. Whereas a lot of hypertension, like what the Asians tend to get from eating high-sodium diets and smoking a lot of cigarettes, they get intracranial atherosclerosis. That's also called Asian atherosclerosis. But they're both those are the two major risk factors, hypertension and diabetes. And the high-fat diets cause both. High-fat diets cause diabetes. They also cause hypertension, but other things will cause hypertension. Too much dietary sodium and smoking tobacco. The other thing, too, is anything that makes the blood thick is going to be an atherosclerosis risk factor. Atherosclerosis is a blood clot, and the gateway diseases are obesity, hypertension, and diabetes. So normal red blood cells about 7 microns. Capillary is about 5 microns, so it has to deform itself to fit through. When you stick the red blood cells together because of bridging molecules, things like LDL cholesterol, IgM antibodies, clotted fibrinogen, elevated uric acid from high fructose corn syrup, now you're like pushing a sandwich of red blood cells through these capillaries instead of individual red blood cells, so pressure has to go up. The reason why you have a blood pressure is to get blood to the top of your brain, your cerebral cortex. So you have to be careful about lowering it suddenly, and when you're pumping thick blood like a milkshake, pressure has to go up. Okay, so if the blood is thickened because of these bridging molecules sticking the red blood cells together, your pressure is going to go up. In addition, sodium is going to constrict the vessel, so they're going to become narrowed. So now you're pumping thick blood through a narrowed system, pressure has to go up. That's why excess dietary salt raises blood pressure. This is why high-fat diets raise blood pressure, because they elevate LDL cholesterol. If you got leaky gut from a lack of dietary fiber, you're going to get amyloid-type clotting, where you change the shape of the fibrinogen. We talked about that in other lectures. If you're eating a lot of high fructose corn syrup or a lot of animal protein, you'll have elevated uric acid. That's not only a bridging molecule, it's also a vasoconstrictor, inhibits endothelial nitric oxide. The higher the LDL cholesterol, the higher the blood viscosity, the thicker the blood is. There's a good video at Dr. McDougall's YouTube channel called Blood Sludge After High-Fat Meal. It's only 50 seconds long, and you see how all the red blood cells stick together and the blood has become thicker. Okay, more than 99% of blood cells are red blood cells. And then you run into the concept of the Goldilocks balance. So what the Goldilocks is about, it's about hypertension. So Goldilocks, wanted things just right, not too hot, not too cold, okay? And, she had to always find what cup is the right size, what's the best bed for her, etc. Okay, so we're going to talk how the Goldilocks balance relates to hypertension. Okay, so here is that internal carotid artery going into the brain. Internal carotid artery travels up into the brain, bifurcates. I'm not showing the anterior cerebral component. I'm just showing the middle cerebral artery here. And I got a skull and crossbones here because this is the most common spot where I see strokes. So basically, if the patient has severe hypertension, they get atherosclerosis in these vessels, and then they can't perfuse this part of the brain because it doesn't have a lot of collateral circulation. If they overtreat their hypertension, like take pills to drop their pressure too fast, then they don't get enough blood to the spot, they get strokes right here. I can see in one patient can have 100 little strokes in this area. Often these strokes are mild, they're called silent strokes at first, but over time they make these patients demented. And that's one aspect of vascular dementia. I'll show you some MRI of what that looks like. So here's a normal looking brain on MRI. It's nice and tight up against the skull. The ventricles are small. There's not a lot of atrophy. The sulci are small. You don't see a lot of white spots in here. This is a flare sequence, which is another name for a T2 sequence with CSF suppression. But what it means is that if you see bright spots here adjacent to the ventricles, all this white stuff here, those are strokes. So this is what I meant by you could see 100 strokes in one patient. So you can count them, 1, 2, 3, 4, 5, 6, 7, 8, 9, and some of them are coalescent, but you get my point. A lot of old people have accumulated many of these strokes. So the typical person who's hypertensive, diabetic, and fat, and eats high-fat diets, they'll have a lot of these, and this is why they get really mentally slow as they get older. But I've seen lots of people who are in their 80s and they have brains that look like this, okay? Maybe the vent's not quite that small, but they maintain really good brain function. And it's easy to do. Just eat the low-fat diet without adding oils. I mean, why not do that? Why make yourself fat, sick, and stupid? If the blood pressure is too high, like they got really high systolics running 180s and up, they'll sometimes get intracranial bleeds. A big bleed like this is rare. I only see one of these every couple of months, once every 6 months, okay? A big basal ganglia hemorrhage from hypertension. But these little small microbleeds, these are very common. I see these every day from hypertension. Typically, hypertensive bleeds are going to be relatively central in the basal ganglia part of the brain, whereas elderly-related, dementia, cerebral amyloid angiopathy type cerebral microbleeds are going to be in the periphery of the brain. But it's not always like that. I will see hypertensive bleeds sometimes out in the periphery, and I'll see amyloid angiopathy related hemorrhages more centrally. So they kind of go together. I actually think amyloid angiopathy is quite related to hypertension. But what I'm making the point is you want to protect your brain cells because it's just like the kidney. You lose a certain number of them and you can compensate, but you lose too many brain cells, then you're stupid and then quite frankly demented. This is just a point about diabetes over time. Here's a normal capillary basement membrane. Here's a thickened capillary basement membrane from diabetes. This is a capillary. These are the red blood cells traveling through the capillary. They're folded back on themselves a little bit because RBC is about 7 microns in diameter. Capillary is only 5 microns in diameter, so it has to fold back on itself to fit. And the little blue circles are the oxygen passing from the red blood cell to the tissue. Like here is a brain cell, a neuron. Okay, the green cells here are the vascular smooth muscle cells, and these become hypertrophied in the setting of hypertension. Okay, so when you hypertrophy the vascular wall and the capillary basement membrane, then less oxygen can get from the red blood cell to the neuron. So you start diminishing oxygen delivery to the tissues, which means you're less able to make energy, less able to make ATP in your mitochondria. So this is why you want to get your diabetes under control with diet and your hypertension under control with diet, because it's going to lead to progressively less oxygen delivery to your brain, and you're going to be progressively losing brain cells, and you don't want that to happen. Okay, when a neuron communicates, it fires an action potential. So here's the presynaptic neuron. It'll receive incoming information through the dendrites, and action potential will be conducted down the axon. When it reaches the axon terminal, calcium will be allowed to enter. This is a voltage-gated calcium channel that's activated by the sodium currents. That'll cause a neurotransmitter vesicle to travel to the synaptic membrane. It'll release its neurotransmitter into the synaptic cleft. That'll exert an effect on the postsynaptic neuron. And this is how the brain communicates. This is how the brain stores memories. This is how the brain, tells the muscle to contract so you can do something. Okay, the key point is that calcium is what runs the show. Whenever calcium comes up in the cytoplasm, that makes the cell do whatever it does. So the typical scenario is that the neurotransmitter will be released, most commonly glutamate. 90% of cortical neurons release glutamate, excitatory neurotransmitter. About 5% release GABA, which is an inhibitory. So glutamate's like flipping the light switch on. GABA is like flipping the light switch off, and then there's the other ones. They're only about 1% in amount, but everybody knows them. Dopamine, acetylcholine, norepinephrine, dopamine, serotonin. Those are all about 1% each, and they're sort of modulators of neuronal function. But glutamate is the big dog in neuronal function. What's going to happen, though, is you'll see here that the concentration of calcium outside the cytoplasm in the extracellular matrix, it's literally 10 to 15,000 times higher than it is inside the cell. Now what that means is you're going to need energy to pump calcium out of the cell cytoplasm. So you're going to need ATP. The ATP is made in the mitochondria. So you need good mitochondrial function. You need oxygen for the mitochondria to make ATP. You need glucose coming into the neuron to make ATP. So that's going to be real important for the brain cell to protect itself. So this is an old picture of Rome, like the Triumph, Arc of Triumph, and you can see all the roads lead to Rome. And when you're talking about neuronal function, it all comes down to what's happening with calcium. The way to understand a neuron is what's happening with calcium. And also, this is also why I tell you that neurology textbooks are a joke, because they'll only have 1 or 2 paragraphs on this. This is the most important thing in all neurology, what's happening with cytoplasmic calcium metabolism, because there's so many things that increase it. And all of these things have what is called an excitotoxin effect and can overstimulate the neuron and cause it to die, especially in the setting of diminished energy production or diminished oxygen and glucose delivery. Okay, so this is how it gets calcium out of the cytoplasm. You use ATP for the plasma membrane calcium ATPase. You need ATP generating the electrochemical gradient of sodium in order to run the NACA exchanger. And then you also need ATP to pump calcium into the endoplasmic reticulum. By the way, I've got much longer lectures all about calcium metabolism, cell physiology, excitotoxicity, how neurons function. But I'm just giving you a quick overview. The key point of this whole lecture is understanding what's happening in the kidney, the same sort of thing. It's a little different in the brain, but it's the same sort of thing, of progressively losing brain cells until you no longer can compensate, and then you're cognitively impaired or demented. Okay, and this is just showing a slide of mitochondrial inhibitors. I got 7 biochemistry textbooks. None of them has anything about mitochondrial inhibitors, but I went through all the papers on mitochondrial inhibitors, and I quickly found over 60 of them, and many of them are very common. F- in municipal drinking water is a mitochondrial inhibitor. Toxic aldehydes like H&E from omega-6 cooking oils, mitochondrial inhibitor. Lead, mitochondrial inhibitor. Antidepressants like selective serotonin reuptake inhibitors, mitochondrial inhibitors. Common medications like statins for cholesterol, mitochondrial inhibitor. Common medications like metformin for treatment of diabetes, mitochondrial inhibitor. Tylenol, mitochondrial inhibitor. Okay, BPA, like in plastics, mitochondrial inhibitor. And there's a lot of them that are real common. Antifungals, like mold inhibitors that they put in all the processed food, they're mitochondrial inhibitors. Alcohol is a mitochondrial inhibitor. So traumatic brain injury leads to mitochondrial inhibition. So all of these things, and a lot of antibiotics do it, and there's other medications. So I just tell you that because a lot of people are exposed on a daily basis to 10 or more of these problems simultaneously. And then this is the Peter Rogers theory of dementia. It's also called the supply and demand theory of dementia. So basically you have a metabolic rate, which is the MR. I'll make myself a little bigger, it'll be easier to see. Metabolic rate, MR, right here. And then you have an oxygen and glucose delivery. And supply should meet demand. If your metabolic rate is increased because of stimulants, so let's say you got stimulants, they increase your metabolic rate. Actually, let me do it this way. Your metabolic rate is increased because of stimulants. Then you need to increase the amount of oxygen and glucose delivered to have that neuron meet its energy demand so it can continue to function effectively. If you have a high-fat diet, diminishing oxygen delivery, then this gap's getting wider. If you have a high-sodium diet, vasoconstricting, the gap gets wider. If you have more stimulants like psychological stress, sleep deprivation, caffeine, they all increase glutamate transmission at the synapse. Smoking tobacco is another stimulant. Ritalin, like for attention deficit medicine, you can see this gap's getting wider and wider. And then if you also throw on top of it mitochondrial inhibitors, those have the effect of lowering oxygen and glucose delivery in the sense that they lower the energy production ability of that neuron. The wider this gap gets, the more likely the brain cells just die. Okay? And so that's my theory of supply and demand, and it's much more useful and accurate than any of the other dementia theories because it tells you exactly what to do. Avoid all the excitotoxin stimulants. Avoid all the things that thicken the blood. Avoid all the things that inhibit your mitochondria. Avoid all the things that inhibit your endoplasmic reticulum, that interfere with calcium metabolism. Eat a healthy diet so you have the right amount of potassium coming into your body so you're not overloaded with sodium like most people are. And you're going to be constantly losing these neurons if you don't do that. And eventually you'll hit a tipping point and you're cognitively impaired. So the good news is all of these things can easily be avoided. So avoid them and your brain will function better and you'll keep a good brain function all the way into your later year. You'll die with a fully intact brain, hopefully when you're 90 or 100 years of age.